The last abstract, it's pregnancy outcome and safety interrupting therapy for women with endocrine responsive breast cancer, primary results from the positive trial, IBCSG 4814, Big 813, presented by Dr. Ann Partridge from the Dana-Farber Cancer Institute. Ann?
Thank you. So, future fertility is of paramount importance for our young breast cancer patients and survivors, and many of them express desire to have a future pregnancy at diagnosis and follow-up. However, there have been concerns that a pregnancy might increase the risk of an early-stage breast cancer coming back, particularly in the setting of a hormone receptor positive breast cancer, where historically people have been concerned that there might be throwing fuel on the fire. Prior studies looking back in registries and databases have shown that pregnancy after breast cancer does not appear to worsen disease outcomes, regardless of hormone receptor status. And yet, standard 5 to 10 years of adjuvant endocrine therapy compromises conception by both the time it takes and women are aging, and then the majority of young women end up receiving chemotherapy, and that can compromise their ovarian reserve, even in hormone receptor positive disease. The positive trial, therefore, was designed to address this clinical conundrum. First, it was the first international prospective single-arm trial to look at the question of, is it safe from a breast cancer relapse perspective to temporarily interrupt endocrine therapy to attempt pregnancy? The study was designed with a protocol for specific inclusion and safety criteria because we could not do a randomized trial in this setting. It just wouldn't be ethical nor feasible. You can see the schema below, and it was very regimented with an 18 to 30 month endocrine therapy treatment required. And then there was a 3-month washout after enrollment to make sure that the endocrine therapies were out of a woman's system. And then women were encouraged to try to become pregnant and get back on endocrine therapy within a total of 24 months or 2 years. And then, of course, they were followed over time. The study enrolled from December 2014 to December 2019 across 116 centers and 20 countries on 4 continents. It really was an international effort. The positive population comprised 516 patients with a median age of 37 years. 75% were nullips. 94% had stage 1 or 2 breast cancer, about split 50-50, and 62% had received adjuvant chemotherapy. The median time of breast cancer diagnosis to enrollment was 29 months, and the median follow-up was 41 months. Here you can see the primary outcome of the positive trial, the breast cancer-free interval, and you can see that it's 8.9% at data lock. The distant relapse-free interval was about 4.5% at data lock. Now we compare it to a very well-calculated historical control group taken from the text and soft cohort, and you can see that both statistically, numerically, and by the eyeball test, that there were no apparent differences in breast cancer-free interval and distant relapse-free interval events between the positive cohort and this historical control. We also looked at whether or not women got back on their endocrine therapy and did a competing risk analysis. And here you can see the cumulative incidences at 48 months of relevant outcomes. 8% of the cohort had cancer recurrence or death before resuming endocrine therapy. There were 9 deaths on study, or about 1.5%. 76% of the patients had resumed endocrine therapy in follow-up by data lock, and 15% had not yet resumed endocrine therapy. Of note, 79% of the women who were disease-free at 2 years who had not yet resumed endocrine therapy at data lock reported continuing pursuit of pregnancy, active or recent pregnancy, or breastfeeding still at most recent follow-up, when, of course, people would not go back on endocrine therapy during that time. Here are the pregnancy and offspring outcomes. About 74% of the 497 women had at least one pregnancy, 70% within that 2 years, with a total of 507 pregnancies. 317 of the whole cohort that was assessed for pregnancy had at least one live birth. That's 64% of all enrolled women and 86% of those who became pregnant. 19% had at least one miscarriage, and 3% had at least one therapeutic abortion. 8% of offspring were low birth weight, and 2% had birth defects. So in conclusion, from these initial results of the positive trial, temporary interruption of endocrine therapy to attempt pregnancy among young breast cancer survivors is safe in short-term follow-up. Most women, 74%, had at least one pregnancy, and most, 70%, had it within 2 years. The incidence of birth defects was low, about 2%, and not clearly associated with treatment exposure. Long-term follow-up, both to monitor endocrine therapy resumption and long-term disease outcomes, particularly in a hormone receptor positive setting, are ongoing. And however, in the short term, these data stress the need to incorporate patient-centered reproductive health care in the care of our young women with breast cancer. I'd like to thank all of the patients and their families. This is not something that women couldn't have done on their own, and so the fact that they did engage in research was very altruistic here. The investigators, data managers, study nurses, and pathologists at the participating center, including the co-lead or the international lead of this study, Olivia Pagani, who could not be with us here today, the collaborative groups and their collaborators, the trial coordinators, data managers, monitors, and collaborators at the IBCSG, which sponsored the study, the current and former members of the IBCSG Data Safety and Monitoring Committee, and our steering committee, and finally, all of our supporters, national funding bodies, charities, and private donors. And these are our disclosures. Thank you.
Thank you. Thank you so much. Questions, please, and while people think about them. So does this mean that 26% of women were unable to get pregnant within 2 years, correct?
Well, that's mixed. Some people had disease recurrence before they got pregnant, and some people, yes, some people either chose not to or were unable to get pregnant within the time frame.
Any reason to consider extending that, again, to 3 years, let's say, or?
Well, it was a very practical study where, and I'll present this tomorrow in the official presentation, the actual time it took for people to get back onto endocrine therapy, the median was actually over 2 years. And so many women did not become pregnant within that first 2 years, but they did subsequently, which is in part why we're seeing some of the delayed getting back onto endocrine therapy. So de facto, they did delay it.
Okay, thank you. Question from the microphone, please.
Hi, Alice Goodman with the ASCO Post. Maybe I missed it, but how do these figures compare with the general population and attempts to get pregnant? I mean,
so it's a very good question, and they actually, it's hard to find a really a cohort that actually is just like this cohort, because we have population figures of women of the same age, and this is a much higher pregnancy rate because the average age here was 37, and in the general public, women are not generally trying to get pregnant as much at the age of 37. This is a select breast cancer population that most of these women were null-ups at that time and hadn't had a pregnancy. When you look at women going to fertility clinics and trying to become pregnant, these rates are actually a little bit lower than that rate.
Next question.
Aaron Talent with Oncology Business Review. Dr. Artiaga, would you care to comment on what this could potentially mean for breast cancer patients who are wishing to get pregnant?
Well, I think this is great news. I think, as Dr. Parch indicated, maybe longer follow-up is indicated, but so far the data would suggest that the risk of recurrence is not any higher for these women who chose to get pregnant, interrupt endocrine treatment, get pregnant, and then resume it.
Thank you.
my question to Johan Partridge has actually been addressed. Rebecca Glass, M3. I have a couple of questions that are for other panel members, but I can wait if there's questions from the
Any
online
questions in
people.
the webcast, maybe?
Yes, we do have a couple of questions. So one question from Jean-Claude Lemaire with Media Scoop. He asks if all of the pregnancies were natural or if some of the patients used fertility treatments.
So indeed, a substantial proportion used fertility treatments, and we'll present that tomorrow.
Second question from the webcast.
Yes, this is from Isabel Whitcomb with Patient Power. A variation on a question that was asked previously, but the first is, in the press release, Dr. Pagani mentioned that only 5 to 10% of younger breast cancer patients get pregnant, although 40 to 60% of patients are concerned about future fertility. Do you anticipate that these results could allow these numbers to change in the future?
I think that's very possible. I do think that women will feel more comfortable trying to pursue a pregnancy in this setting with these fairly reassuring data.
And Isabel's second question is, do you anticipate a future change in the kind of advice that young breast cancer survivors hoping to get pregnant will receive from their medical care providers?
Yes, I do. I do think that people have tried to do this. These are decisions we make in clinic every day, and I think that these will help patients, their families, and their doctors to feel more comfortable, at least in the short term, with these data to pursue a pregnancy and interrupt, not stop endocrine therapy. And I think that's an important part of the message as well.
Thank you.
Thank you. Dr. Turner, it was a quick one. The ATK pathway is really important in TNBC patients as well. Do you think this combination therapy will be of benefit to them?
Well, there's an ongoing trial assessing capivasertib in triple-negative breast cancer, so we will need to wait for the result of that. Trials are also ongoing in prostate cancer as well, where the AKT pathway is important with capivasertib. So there's a number of phase 3 trials that will report out in the next year or two.
Thank you. And Dr. Oliveira, it shows that there's a reduction in ESR1 allele frequency. Do you feel this will inevitably result in resistance within these cancer cells to the treatment?
Sorry, I missed it. Could you please repeat the question?
Sorry. It showed a reduction in the ctDNA allele frequency. Will this result in resistance to the therapy as treatment ongoes?
So, if I understand correctly, you are asking whether the reduction in the variant allele frequency correlates with disease resistance.
Yes, to the therapy.
So, there is a piece of information missing in this data that we have not analyzed yet. It is the samples at tumor progression, the ctDNA variant allele frequency at tumor progression, and it will be important to assess if actually one of the mechanisms of the resistance to camizestrant is again the rise of ESR1 mutants. But I would guess that there may be other mechanisms of resistance to the therapy.
Thank you.
Maybe I add to that. It's possible, okay, that this resistance to this drug eventually, and these tumor cells may acquire new mutations that again bypass the binding of the drug to that mutant receptor. That is possible, but I assume you're following those patients with
Yes, exactly.
with further symptoms. So that'd be interesting. We don't, but you would have to wait until patients progress, if they progress, and see whether there are acquisition of new mutations. That has happened for other targeted therapies.
Mm-hmm. Thank you.
Any questions in the webcast before we close? No? Okay, well, thank you very much for being here.